Good afternoon, everybody. I'm Jenny Phillimore, Professor of Migration and Superdiversity, and I'm chairing today's event. I'd like to welcome you to Migration and Vulnerability During the Pandemic, Barriers to Wellbeing. We want to thank the wider Society from Your Sofa Festival for their support with organising this event, and they're part of the nationwide and annual ESRC Festival of Social Sciences, which is somewhat different this year because, of course, it's all online. The purpose of the ESRC Festival of Social Science is to showcase pioneering social, economic and political research and how it impacts on everyday life. So it covers a whole myriad of topics. We're recording today, and eventually in a couple of weeks, the recording will be available on the University of Birmingham YouTube channel. So if once isn't enough, you'll be able to listen to us again. So let's move to the first slide, please. Let's just quickly run through the schedule. So I'm going to introduce in a moment the panelists, and that'll take us through to about 12:10, where Laurence Lessard Phillips is going to be talking about the project and the data that we are using. Lin Fu after this will be sharing some of our initial results with you. We've been busily pulling these together for today's event, and then we'll move on to two experts from Doctors of the World and Docs Not Cops, talking about their reactions and also relating what they see in the data to experiences in their everyday work. We'll then move on to a wider response from the researchers on the project, and then we have a question and answer session. Now, the way, could we move to the next slide, please? The way that this works is that obviously we're keen to share with you our results and our highlights, but we're very, very keen to have an interactive experience here. It's early days for this project, so you know, questions and comments are particularly important in shaping how we move forward. Obviously, we want to have a respectful and courteous discussion. And we're encouraging you to ask questions. And the way that you can go about this, or the way we're asking you to go about this, is to write your questions into the Q&A part of Zoom. So please do not put your questions in the chat box, because when I'm looking for questions, I shall be looking in Q&A. And we ask you to just do that as you go along. You don't have to wait to the Q&A session, but as you're listening to the presentations, put in your questions, and then we can work out how we're going to go about that once we get to the Q&A session. Now, we ran an event yesterday, and one of the things that comes through is that the way that this webinar system works is that you can't see each other, and frankly, we've got no idea who is out there either. So it would be really good if you want to admit to being here on this webinar, if you were to introduce yourselves via chat and say where you are from. So just put in, you know, I'm Jenny Phillimore and I'm from the University of Birmingham. So we know who's out there and you know who's out there as well. You don't have to do that. It just gives everyone a stronger sense of who the audience is. Okay, that would be wonderful. Right, the next thing I'm going to do is to introduce our speakers. So let's start with the panelists. We have got Laurence Lessard Phillips. She's a senior research fellow at the Institute for Research into Superdiversity at the University of Birmingham. And she's very much interested in perceptions, measurements and dimensionality of immigrant adaptation. She's interested in ethnic inequalities and transnational behaviour against across immigrant generations. She's involved in a lot of projects related to the above, but most importantly, she's actually the PI, so she's the project or the principal investigator, the project lead of this wider project, the Migration, Vulnerability and Wellbeing Project, which she'll be talking about in a minute. The next person I want to introduce is Lin Fu. She's the research fellow on the project, and she's a quantitative researcher. Her current work is focusing on the well-being of groups at risk of vulnerability. She completed her PhD in economics in 2020, where she worked on the determinants of health compromising behaviours in China, including looking at smoking, heavy drinking, physical inactivity and obesity. Next, we move on to Rita Daoub, who is the senior officer in the policy and advocacy team at Doctors of the World UK. And she is their lead on access to primary care, and she's got a wealth of experience in global and public health. Then I'm going to introduce you to our second panelist, Yajur Arora, who is a fourth-year international medical student at the University of Birmingham, but a founding member and the chair of the University of Birmingham branch of Docs Not Cops. They work closely with Docs Not Cops in Birmingham and MedAct to help individuals understand the impact of the hostile environment in the NHS towards migrants and vulnerable populations. Yajur is very passionate about the role of public health and health policy in trying to promote changes to this environment. And as a future clinician, so part of our future, very important, he understands the part that all professionals in a healthcare setting have in challenging and changing unethical and divisive practices. Now, finally, I'd like to introduce Penelope or Pen Mendota, who you can't see, but she is illustrating the whole event. She won't be drawing pictures of anyone's faces, she's capturing the main themes, and we will be able to look at her illustrations later, and they'll help us understand and make sense of the conversations that happened today. She's an independent graphic facilitator, a cartoonist, and an academic with more than 25 years of experience working in these areas. Her graphics are widely published and they've been translated into lots of languages. She originates in New Zealand and she's got mixed heritage, and she's lived in India and the Middle East. Her background is in social care, facilitating co-production, anti-racist and interfaith initiatives, and she's developed the concept of values-based cartooning, and that's what she's going to be doing today. On that note, I'm going to be handing over now to Laurence, who is, so if we can have the next slide, please. And Laurence, over to you to introduce the project and the data.
Lovely. Thank you very much, Jenny, and welcome everybody to our panel discussion. So the results that we're going to focus on during this presentation are part, as Jenny said, of the Vulnerability, Migration, and Wellbeing Project, investigating experiences, perceptions, and barriers. So this project is funded by the Nuffield Foundation. Thanks to the Nuffield Foundation. And it comprises a team from the University of Birmingham, including myself as a PI, our chair, Jenny Phillimore, and Sheila Den-Meyer, Lin Fu, and colleagues from Doctors of the World, including Rita Daoub. So the overall aim of the project is to investigate the well-being profiles of individuals at risk of vulnerability. And within that project, what we're doing is that we're focusing on migration and on migrants. And we're trying to investigate in this project the factors that influence well-being, as well as trying to develop some profiles of well-being. For that, we're using a mixed methods approach. And the data that we are using is collected from the clinics that are run by Doctors of the World, which means that within that mixed methods approach, what we are doing is that we're analyzing questionnaire data, so quantitative data, from a quantitative perspective, but also some of the data is analyzed from a qualitative perspective as well. And we're planning on carrying some interviews with volunteers in order to help us contextualize our results a bit further. So in that bigger project, the aim is to pull and analyze data from Doctors of the World from 2011 until 2018. So that was the original aim of the project, but since then, we also secured some funding to carry out a sub-project that is looking into the main themes of vulnerability, migration, and well-being, but during the pandemic. This is to provide a picture of the current situation, the situation in 2020, given the circumstances in which we find ourselves at the moment. So with the great help of our colleagues at Doctors of the World who are involved with the data, we managed to access the data for the first 9 months of 2020 to provide such a picture. And this is what we'll discuss today. So you might be curious to know a bit more about the data that we are using for this larger project. And also for this, we're using for the sub-project and the larger project, as well as this presentation. So as I briefly mentioned, this is data that has been collected as part of the clinics that are held by Doctors of the World in London, but also mobile clinics. And to directly quote the website of Doctors of the World when they discuss what the aims of the clinics. So the clinics offer primary care and health and social advice from volunteer doctors, nurses, and support workers for excluded people, such as asylum seekers, undocumented migrants, homeless people, and sex workers. So these are the main people who tend to visit the clinics. So we are using data that is being collected as part of those clinics. And the data that we are using is anonymized, and it's anonymized so from the individuals that are attending the clinics. So we call them the service users. So when we refer to service users, this is who we mean. And then we're getting the data from questionnaires that are being administered during the consultations and completed by the volunteers. And these are questionnaires that are focused on the service users. So there are two main types of questionnaires. The first one includes a social questionnaire, which covers information about the service users, such as their demographic information, living conditions, main activities, immigration situation, and health coverage and barriers to healthcare. So that's part of the social questionnaire. What we also have as part of that data is information from a medical questionnaire, which is completed whenever service users end up undergoing a medical consultation as part of the consultation. Note that this is not all service users who actually undergo a medical consultation. So we have more information from social questionnaires than we have from medical questionnaires. So this is the survey data, which is data that has been quantified. So this is the quantitative data that we're analyzing as the main part of the overall project, but also the sub-project. What is also very interesting about this anonymized data is that as part of the consultation data, there are also notes, anonymized notes from each individual consultations that are completed by the volunteers. And these are notes that we are planning on analyzing in order to provide more context to the questionnaire data. So this is, in a nutshell, a bit more information about the project and the data. And what we have, and now that you know a bit more, so what I'll do is that I'll now pass it along to my colleague Lin, who will discuss some of the preliminary results that we have and that we want to share with you, and that we find are very exciting to share. Thank you. Next slide, please.
Thank you, Laurence. Hello, everyone. Thank you for attending our digital event. My name is Lin. Let me show you some preliminary results from our project. As mentioned by Laurence, with this project, we want to investigate the well-being status of people at risk of vulnerability during the COVID-19 period. And we also want to find out the barriers they are faced with. So firstly, let's look at the line chart on the left. It shows the number of service user consultations per month. we can see that there has been a significant drop in the number of consultations from February 2020, and especially since the start of national lockdown in late March. In response to the pandemic and to the lockdown, Doctor of the World moved to providing telephone consultations, which had an impact on the numbers and the access to consultations. During the pandemic, the total number of the consultations since the 23rd of March is 318 consultations in total. This is the maximum number of responses on which we build the following results, which is out of 750 total consultations from January to September. On the right-hand side, we show the demographic profiles of the service users who had a consultation during the lockdown period. Males accounted for 52% of the total consultations, and females accounted for 48%, which was not a significant difference. Around half of the service users were young adults aged from 18 to 34 years old. 9 out of 10 service users claimed that their monthly income was lower than the poverty line, which is £836 per month, a slight increase from before the lockdown. These results show that the financial situation is a big issue for the service users. Apart from the income, service users' living situation also draw our attention. 63.1% was reported living in insecure or inadequate housings. With regard to the immigration status, 31% of the service users during the lockdown period were asylum seekers, different from the pre-lockdown figures, where only 6% of the service users were identified as asylum seekers. The data from Doctor of the World also shows that, compared with the pre-lockdown, an increasing number of the service users reported having some sort of health coverage, yet they are still using the service from Doctor of the World. Next slide, please. From this slide, it presents the consultation needs of the service users. We list almost all the possible reasons why the service users contacted Doctor of the World during the pandemic. We can find from this graph, from this word cloud, the larger words indicating a higher number of mentions in the data. So we can find that during the COVID-19 period, GP registration is the most important reason why people seek help from Doctor of the World, which is similar to the pre-lockdown pictures. The other most often mentioned reasons for consultation were queries such as NHS costs, antenatal cares, and immigrations. It's also very interesting to note that the mentions of antenatal care, secondary care charging, and the termination of pregnancy increased during the lockdown period, if we compare it with the other consultation needs. Next slide, please. So for our project, our main aim is to investigate whether service users' subjective health status has changed during the lockdown period. So we checked 3 indicators of the well-being, namely general health, interest in doing things, and feelings of depression. This covers both the general and the mental health. Firstly, let's look at the first chart on the left. It shows the general health status by immigration status. There are 3 immigration status, including legal status, asylum seekers, and undocumented status. we can find that more than half of the legal and undocumented service users were reported to have good health, as shown by the dark pink bars from this chart. However, 35% of the service users who were asylum seekers reported bad or very bad health status, as seen by the light pink bars from this chart, which is almost twice of that of the other two groups. Compared with the pre-lockdown situations, we also find that the general health status became better for the legal service users after lockdown, but it became worse for those undocumented service users and asylum seekers. The second bar chart on the right, it shows the little interest of doing things during the lockdown period. From the result we can find is quite positive, with up to 60% of the service users stating that they didn't notice little interest in doing things during the lockdown period. We can find these figures are quite consistent with the pre-lockdown and the lockdown situations. For the last chart in the bottom right corner shows the percentage of the service users feeling down, depressed, or hopeless during the lockdown period. If we look at this chart from the bottom to up to 60% of the service users reported that they didn't have any experience of depression or feeling hopeless during the lockdown period. On the other hand, around 30% of the service users reported these kinds of the feeling at least several days a week. This represents a slight increase from the pre-lockdown pictures. Next slide, please. The last slide, it lists the main barriers that service users have experienced when they attempt to access healthcare service in the UK during the pandemic period. The ranking is based on the numbers of barriers mentioned by the service users. If we look at from left to right in order of importance, the barriers are lack of knowledge or understanding of the system and rights, administrative and documentation barriers, fear of arrest, financial barriers, denied health coverage, and denied healthcare by a healthcare provider. We can see that the service users were faced with many barriers during the lockdown period, with most of the barriers are often mentioned during the pandemic period. That's all for me and for our preliminary results on the well-being of the service users during the pandemic, as well as the barriers that they are faced with. Thank you for listening.
Thank you very much, Lin. We're going to hand over now to Rita, who's going to give us her reactions to the findings and maybe connect them with some of the actual experiences that you know about from working at Doctors of the World. Over to you, Rita.
Thanks, Jenny. Hi, everyone, and thanks for having me on this digital webinar. I think I'll start by giving a little bit of context, particularly about on why patients and why service users contact us and why they come to our clinic. One of the main issues that we've seen repeatedly throughout the past 10 years is that people are wrongly denied registration with a GP. Now, according to the NHS guidelines, everyone residing in Britain, lawfully or not, is entitled to register with a GP. This is a universal right for everyone. However, we still see a lot of people being denied this right and denied registration, although this has massive consequences, not only for accessing primary care, but because accessing and registering with a GP is usually the main gateway to the NHS and gateway to all the other health services. So in the past years, almost 20, we've documented around 20% of that. Almost 20% of people accessing our services were wrongly denied registration. So that's just a little bit of context, because I think this is a very important point. So the results are very interesting because they are highlighting changes that we see. Some of them probably we all probably can relate, particularly to the deterioration of mental health and like feeling, probably depressed and feeling stuck, and we probably can all relate to that. There are a few points that I think are very, very important and highlighted by these results, mainly the situation of asylum seekers. And we see that we have like almost 5-fold more asylum seekers calling us and seeking help with the different barriers of accessing healthcare. The second one is digital exclusion, which meant that not only that the numbers dropped, is also the numbers of people being able to register with a GP. So even though they call our helpline and even when they get the online consultations, we have, I think, 6% less service users who eventually are able to register with a GP and access the services they need. And the third one is the highlighting lack of knowledge as a barrier to healthcare, which is something that we probably all experienced this, particularly during March and April, where a lot of us were not really sure what was happening, what is allowed, what is not allowed, what is COVID, how to deal with it. Everyone was confused, and our service users were no exception. Unfortunately, this continues until now. We're like the 8th month throughout the pandemic, and we're still, our service users still experience lack of knowledge as a barrier to healthcare, mainly because of the lack of the translated resources, translated information, accessible information, and not knowing where to find this information. These are the main these are the main points. One last point is about needing information about the NHS charging. Just a little bit of context as well here. Secondary care is chargeable for certain categories of people who live in the UK, namely undocumented migrants. We've seen lots of devastating consequences as a result of the charging regulations. However, during COVID, it was decided that testing for COVID is free for everyone, regardless of their legal status in the UK, and also treatment for COVID. And this created lots of confusion, because if you go to the hospital, if you do a test and you are negative, you don't have COVID, you will still be charged for whatever reason you are in the hospital for. And this has a deterring effect. So many people, if they know that there's a potential that they will go to the hospital and they don't have COVID, and then they will incur thousands of pounds of charges, then that is a deterring effect, and they will not seek medical care. I'll stop here, and hopefully we'll have a chance to elaborate more on these points.
Okay, move to the next slide. Thank you very much, Rita. And we'll talk to Gajur now, please.
Hey, thank you guys. I think it kind of ties in really well with where Rita ended off about the charging in secondary care settings as well, in terms of the kind of work that our organization does. So just think a bit of a small thank you, big thank you actually, to Doctors of the World and Iris and everyone that's collaborated to gather this data, because I think it's a goldmine of information, especially considering the fact that there's such a dearth of data backing up the kind of hostile environment that's present. And I think this is just brilliant. It's amazing that we can reflect on it and that we have guidance and more areas to look at starting from this data. And I think it just reflects how much the system puts stress on vulnerable populations through administrative, legal, and social systems. Because that was one of the primary reasons for people approaching consultations with GPs as well. So I think breaking it down, obviously just want to interpret the results, how that ties in. Secondly, how that ties in with our work at UOB DNC. Third, about like what we're told compared to what the facts are. And last is about how this study is important at a public health level as well. So I think looking at the results itself, it's no surprise that the number of consultations per month have dropped. It's already a reflection of a system that has several barriers and systemically prevents people from vulnerable populations and migrant backgrounds from accessing healthcare. So it's no surprise that in the time of the pandemic, this has gotten worse. With regards to the barriers in terms of lack of knowledge, the administrative barrier, fear of arrest, financial barriers, denied coverage, these are issues that we've seen in our experiences with different patients that have contacted Docs Not Cops. But again, lack of knowledge and administrative barriers were very primary reasons even then. I think that a lot of the work that we've done with Docs Not Cops and the Patients Not Passport campaign, there's been a lot of emphasis on allowing people to know their healthcare privilege, allowing asylum seekers to know what they're allowed and what they're not allowed. So just reinforcing the fact that these people have the right to be registered at GP. It was a big motivation behind Docs Not Cops, and actually kind of the essence of what it started with, trying to combat the hostile environment. And well, the name Docs Not Cops essentially is that these centers of care and these primary points of care cannot be used as a part of the Home Office, and doctors are not border control guards, and people shouldn't be deterred from accessing or seeking healthcare because of these reasons. So previously the Home Office had right to access patient information and addresses via the GPs. And after a lot of pushback, finally the BMA has also confronted this. There's been the issues along scrapping charging altogether, something Rita was briefly speaking about. And this is a part of the hostile environment that we're trying to combat. So that's something that we're hoping will directly combat the administrative barrier and prevent that lack of knowledge. So once everyone knows that, well, you know, these people are allowed, these populations are allowed to come and have access to this healthcare, that barrier will hopefully start to go down. So kind of, again, with what we're doing at DNC, we want to educate healthcare professionals of the future to know what their patients should be able to expect, rather than them both being equally clueless about what the situation is. A lot of times doctors don't know, or clinicians don't know what their patients' rights are, especially when they fall under these categories or these populations. So I think going ahead, looking at how it impacted the well-being. So the high amounts of impact in terms of the asylum seeker population, about 30 to 40% of people reported that their mental well-being was, that the current environment was a detriment to their mental well-being, on top of an already stressful and difficult time for them. It also said nearly 1 in 2 of these individuals experience low mood, which is one of the primary criteria when you're looking at depression by a clinical aspect using ICD-10 and diagnostic criteria. So experiencing low mood, little interest and pleasure in things that they usually would be finding joy in, feeling down or hopeless, that all ties in directly with really detrimental impact on people's mental well-being. And those are very worrying signs. And the fact that, well, you can look at something and say it's 40% or 50%, but that's 1 in 2 people. So I think additionally, when I saw the same result as well, I was, the other part of it was people saying how they felt the health was, whether it was fair, whether it was really good or poor. And I think the first thing that came to my head was, what kind of connotation do individuals from different populations attach to what good health is? And then I had a closer look at the study conducted, and I think the pilot study. I think one of the points it mentioned was that upon the interviews and discussions with a lot of the patients, they did find a difference between what people's expectations of good health are, or what they believe good health is, and actually what they thought was good health was not actually good health when you look at a clinical setting and you look at what we're taught as clinicians and as healthcare providers should be good health. So again, it's interesting how we collect this data and then how we can see how directly it has results in people's experiences. And it's unfair, I think, personally for me, it's really sad and unfair that individuals are made to lower their standards or their expectations. And because they're not given the right or the access to know what is good for them, or what, or being educated from a healthcare point of view, they're already coming in with lowered expectations. And the fact that these people have gone through, a lot of the people coming through these routes, being asylum seekers, have gone through some terrible, terrible experiences, and their baseline level of what would be good healthcare and what they think is good health is so vastly different to the normal everyday person that would be born and brought up over here. So I'm not surprised to see the impact that had on their general health. Additionally, the fact that a lot of asylum seekers, there's so many barriers in place to them being allowed employability and them being allowed to have economic, to live a decent lifestyle in terms of their finance and economically. It's just the fact that it kind of further adds to that. Employability has so many impacts on people's mental well-being, has been proven through several studies, and the fact that that's another barrier that prevents, that will directly impact people's well-being. And also when people have come in to, through the asylum seeker pathway and are waiting upon their status, the amount of money they're given by the government to live on is really, really low. It's amount of sums that would just about cover living costs and nothing else. I think it's between the range of £100 to £200 per week. And it's just not something you can survive on. That's not, yeah, it's a really, really low amount in terms of what you're expecting them to do and how you're expecting them to integrate into the society. So just to wrap up, I think speaking again on the administrative barriers, I think it's really important looking from the other point of view of looking at the person delivering the healthcare, what their knowledge is, like I previously mentioned. But there's something called Ovum Officers in a lot of healthcare settings, which are overseas visitor managers, like Rita had mentioned in secondary care settings. These people are actually supposed to be in charge of knowing what the patient's rights are, knowing who should be charged and who shouldn't be charged, although we believe that no one should be charged. But they've been in charge of doing some really terrible things, like having someone come in with a condition that is going to have, they'll be there on the bed, and they've had people come in and give them a bill worth thousands and 10,000s of pounds, while these people are really, really ill and could potentially be put on palliative care pathways. And that's just inhumane, on top of the fact that it's incorrect in so many ways. So it's trying to break down these barriers. The fact that a lot of these Ovum officers themselves don't know what they're supposed to tell patients or to tell healthcare professionals is very disappointing, and just goes to show the problem there is in the system. And it's funny because if you look at the history of the UK in terms of what it ratifies in terms of giving people healthcare, they've signed constitutions by the WHO, the Universal Declaration of Human Rights, the International Covenant on Economic, Cultural and Social Rights. And all of these have dated back to 60, 70 years. And they keep reiterating the fact that every person, regardless of the background they come from, regardless of the race, religion, or their status in the country, should have access to healthcare. And the fact that this is an issue that dates back to 70 years and not much of it has changed is even more disappointing. I think using this knowledge, it's important to then understand the context of public health and why this is actually detrimental to not just the people who are being made to be treated this way, or being made to have this inequitable healthcare, or having inaccessible healthcare, but everyone else on a larger scheme. The fact that a lot of these individuals will not, because of their fear of things like arrest, because of the lack of knowledge, which is not provided to them by the government when they come here, and it's an alien environment for them, there's no support in terms of giving them the knowledge. The fact that a lot of individuals from asylum seeker or refugee status backgrounds would not access healthcare because of their fear until their health significantly deteriorates, has a terrible impact on them, terrible impact potentially if they have infectious diseases on a larger population. And also the fact that it's kind of counterintuitive to this whole argument that a lot of people project from the opposition about how this is placing a financial burden on the NHS. Well, actually, if you force these people to come in much later because you're making them scared, it's going to have a much larger charge because of the fact that they will require a lot more healthcare. And also the notion that only 0.3% of the NHS budget is actually allocated to healthcare tourism, out of which an even smaller amount would actually go to people in these populations. So that's one thing about how significantly their condition deteriorates before they report. The other part is that they will turn away from being offered vaccinations, which again has a problem in a public healthcare setting to larger populations, and will promote the spread of infection, and ties in with like how infectious diseases such as now COVID could have problems or connotations to larger populations, and how there could be more infection outbreaks. And I think that in terms of the antenatal and postnatal care, so another Doctors of the World study had shown that women are generally put off accessing these types of care, and this increases the risk of their own pregnancy complications for the mothers and the babies. And multiple women have sent in reports of being sent threatening letters from the NHS or debt collection agencies as a result of not paying their charges, which they were told about after they received care. So it's really unfair and often a cruel system. And the funny part is that a lot of these charges that people are placed, well, they shouldn't actually be charged. It literally comes down to administrative issues or lack of knowledge from the other side, so which is the side of the people delivering the healthcare. So I think using the data that the studies gathered, using the kind of sentiment that people are perceiving on their side of when they're coming to access the healthcare, it's really, really interesting. And I think it opens up so much room for reflection now that we have the numbers and that we have the facts and we have actual insight of people's experiences on a large scale. And yeah, I'd just love to see how this would carry on further, how we can continue to explore this and continue to apply it in different settings around the country. So that's just where I'd like to leave it off in terms of my reactions and my experiences.
Thank you very much. We're going to hand back now to Lin and to Laurence, who are going to respond to Rita and Yajur's comments.
Yes, thank you very much, Jenny. Actually, I think I have some questions. I have a couple of questions, and I think Yajur, what you said about the knowledge going both ways, the knowledge kind of also coming from the other side, I think it's a very interesting, it's a very interesting issue to think about knowledge coming from both sides, from, let's say, the service users to use the kind of the data terminology, and also the people within GP surgeries, for example. And I was actually, my first question would be, I was wondering whether you could say a bit more, could you say a bit more about the types of administrative barriers, perhaps especially Rita, when your experience that in collecting the data, the volunteers I might have mentioned, because I think from the data that we have, that's I guess the drawback of having questionnaire data is that you can't really elaborate on the types of barriers. But if you could say a bit more about those barriers, which I think Yajur kind of mentioned a few, that would be greatly appreciated. Thank you.
So in terms of accessing primary care, it's all sorts of reasons. As Yajur mentioned, there is a lack of knowledge, and many clinical and non-clinical staff working in primary care do not know who is entitled to what. Even at the level of secondary care, there are certain groups that are exempted from secondary care charges, such as survivors of human trafficking or rape. And if this is not flagged to the OVMs in the hospitals, then the patients do end up being charged, so wrongly charged. We see a lot of gatekeeping behavior in GP surgeries, where because of the workload or for different reasons, receptionist staff might end up deciding that certain patients are not entitled to accessing primary care. So it's all sorts of stuff. Sometimes we have cases where the receptionist just refuse to register a patient without giving us a particular reason. They will be like, no. One worrying thing that we noticed is that fortunately there were only few surgeries had a blanket policy of refusing to register any migrants. Like, if you're not British, we're not going to register you. That was very, very worrying. And obviously we were involved in talks with them and with NHS England to solve this issue. And through our policy work, we make sure that this communication is not only communicated from our side, but also from the central NHS management side as well, and from the CCGs and the regional primary care bodies as well. So digital exclusion and the shift into the digital models, this is now increasingly not only a barrier to patients, but also a barrier to health providers as well. With no previous experience in doing everything remotely, it is extremely difficult for everyone, for us as well. It's difficult for everyone. So, but then it's more crucial here is because this is a situation, we are in the middle of a pandemic, and accessing care is more important than ever, not only for the individual health, but for the public health as well. So it's more important than ever to make sure that everyone has access to healthcare. But then we have the digital barrier where not only that people might not be able to use digital tools, but there might be reasons that they might simply can't afford the data for their phones. They don't have a laptop. They can't even afford a phone call. And unfortunately, we saw many service users who were struggling with this, and things that we probably take for granted, but it is very, it's a crucial thing for them. And as you mentioned, with the limited support that they are getting already, they just find themselves that I either buy food to my children or I call the GP, and they will definitely choose to buy food for their children. So we have a plethora of reasons here and plethora of barriers, and we are all trying to kind of understand what is happening and try to find solutions. But then it is obviously an effort, like it is just the situation keeps changing, and it requires the actions from everyone to overcome these barriers, or even to help starting overcome these barriers. I hope this answers your question, Laurence.
Yes, thank you very much.
Laurence and Lynn, did you want to add anything else?
I had a quick query about the COVID and because I know, Rita, that as part of the kind of screening during the clinics, there's been a bit of a screening for COVID. So do you have a bit of a gauge of how many service users, for example, called and exhibited any symptoms, and what they have been, if there's indication of what they've been doing afterwards?
I don't have the figures. I know that it was not as high as we expected, but most people were asking about information about COVID, and obviously they realize that the crucial point here is to register with the GP, because this is the gateway to accessing care. And most of the queries were about information about accessing GP services, registering with a GP, and NHS charging. I don't have the figures about how many people actually exempted, shared that they have symptoms of COVID.
Thank you very much. I think these are all the pressing questions that I had. Jenny, do you have questions by any chance?
I do, and so do some of our audience. So I'm going to use chair's privilege and ask one of my questions, then I'll move on to the audience questions. The situation of asylum seekers figured very heavily in that data, and it looks pretty dire, it has to be said. Obviously, one of the things the team has done is tried to present a comparison. It's early days, but a comparison between what's happening with Doctors of the World services pre and during the pandemic. And one thing that comes out is that asylum seekers have got worse health, and that it's deteriorated, or the signs that it's deteriorated for asylum seekers, and the number of asylum seekers using the services as a proportion of overall users has increased as well. Now, some people will be aware that for many asylum seekers, particularly those newly arrived in the country, they're not being dispersed to asylum housing. So they're being kept in hotels in very constrained conditions. Some of the asylum hostels have had quite intense hotspots of coronavirus, and there's very little opportunity to self-isolate. So there's high levels of fear. I wondered how much, from a Doctors of the World and also Docs Not Cops perspective, you feel the asylum seeker situation, the deterioration that we see in the data relates to current government policy, or if you have other explanations, and looking forward, how can we improve the situation for asylum seekers, given that there is no end in sight in this pandemic in reality? What could we do to make things better? So sorry, that was 3 questions, but one main topic.
Sorry, do you want to go first? Okay. Yeah, I think this is really interesting because one of the professors that we worked with over the summer, she's a researcher in Aston University, and a few of them collaborated to make a study on, it was a very brief study on how, this is close to the start of the pandemic and the lockdown, the first lockdown that we had in like April, and it was to kind of look at the impact, and the study revolved around submission of evidence on the disproportionate impact of COVID-19 on ethnic minorities and women in the UK. And it also had a detailed part about asylum seekers. So what you were saying, Jenny, about how a lot of people have moved out of the accommodations provided by the National Asylum Support Service. So that's very true. What happened when the pandemic hit was that these areas that are provided by the NASS to asylum seekers in terms of accommodation are already very crowded without, and often people come in with families and things like that, but there's not much provision in terms of, oh, if you have a family, that you'll be given much more space or area than you would if you came by yourself or with one other person. It's just, they're very cramped environments already. And what a lot of people faced as soon as the pandemic hit was that the NASS was not providing them with hygienic environments, wasn't providing them with adequate PPE. And a lot of people moved out of these accommodations in fear of catching COVID, which kind of tied in with another problem, which was homelessness during COVID. So it kind of shows you how bad the situation was and how fearful people were, the fact that they chose to leave accommodations, even if they didn't have potentially another place to stay for periods of times. The NASS did not increase budgets and allowances for asylum seekers at the time of the pandemic, which made things so difficult, such as there was already inaccessibility to PPE. Masks that were coming out at horrible prices. And because there was no increase in that budget, it kind of worsened an already not very good situation. And the other thing that kind of tied in, which made it even worse, was that a lot of asylum seekers would rely on support from charities for things such as clothing or food banks and things like that. But because COVID-19 hit everyone so hard, a lot of these charities were also forced to shut down. So many avenues of help were shut down simultaneously while the NASS didn't increase the support that they should have given directly to these people. So I think the direct source that you'd hope would help improve the situation would be the government, and through the NASS program, and holding them more accountable to try and provide more protection for people in these populations, for individuals in these populations and families, and to do the right thing and give them more allowances at times such as this. And the other thing was also about status. In terms of asylum seeker status, makes a big impact on what you can or can't access. So if you are an asylum seeker, but you get refused asylum seeker status, you have a small period of time in which you can stay in the country and then reapply to be an asylum seeker again. But in that few weeks, you're technically a refused asylum seeker, which means you don't have access to a lot of support services that someone that has a pending asylum seeker application would have. So it's very complicated pathways with very little help from the government and very little help from the services that are supposed to look after asylum seekers and people coming into these pathways of migration. And I think addressing those needs, identifying them first, was really important. And secondly, addressing them directly by holding them accountable, by increasing, even if it's by increasing the weekly budget by about £50, it's something that would go a long way in allowing people to have access to sanitizers and masks and things like that. So yeah, I think that's probably the first source that you have to hold accountable, and trying to find support for the charities and trying to promote the charities that are trying to assist these individuals. Can
I add 2 points? just building on Yajur's last point, also a lot of people found themselves in a legal limbo because the Home Office suspended dealing with all these applications. So it basically prevented a lot of people who ended up having, who will probably end up having successful asylum applications. They were still in legal limbo because the Home Office couldn't, obviously suspended all dealing with all these applications. So the number of asylum seekers increased, and that is not because the number actually increased necessarily. It's mainly because the applications were not dealt with and they were not processed. So that was like the legal limbo issue. One thing that we very recently in the last I think month or two, we realized, after having lots of discussions with different stakeholders and building on an analysis that we did actually last year, but it's unfortunately still relevant, is the disconnection between accommodation services and health services. So we know that asylum seekers are hosted in hotels or hosted, the Home Office is responsible of providing accommodation. However, the Home Office is not responsible of providing or making sure that the health services are delivered. It is usually the CCGs in the local areas where these accommodations exist. And we noticed that there is a disconnection or a lack of communication between the accommodation providers and the CCGs, or like the health providers in this area. A lot of the time, the accommodation is set and people are hosted there without, and the CCG is not really notified. So there is a gap where there's basically no one providing health services for people in this accommodation. The same thing extends to homeless accommodation as well. And this gap means that this is crucial during a pandemic, because you really need to make sure that everyone is screened and everyone has access if they ever have symptoms. And there is also no systematic approach to providing healthcare in these asylum accommodations, because it's up to the CCG to decide based on the funding they have, based on their resources, and based on their local area, on the demand in their local area, what kind of services they can provide. Or do they basically, some CCGs decided that they will probably send a team to provide health services 1 day a week, still not enough. In some cases, the dedicated GP surgery was a few miles away from the accommodation. So it's either that people will need to walk all the way there, or that they will need to be crammed in a car that will take them at dedicated times during the day. That is like basically a high risk situation, because you don't want people to be crammed in one car. And also, these two factors can contribute to everything that Yajur mentioned. It is extremely difficult to self-isolate, to keep social distancing. They are sharing facilities, they're sharing kitchens, they're sharing facilities, they're living in a shared accommodation. It's almost impossible to do any social distancing. One last point that I want to add, just conscious of time, that going back to the lack of information. So Doctors of the World has a group of experts by experience who are migrants, asylum seekers, refugees, and they advise Doctors of the World on their policy, on our policies, and on our ongoing work. And a lot of them, many of them actually still live in shared accommodation, and they highlighted the issues that when you have different people from different cultures speaking different languages living in one building, it's never enough to send information in English, and the cultural differences need to be taken into consideration, like very seriously, because if it changes and influences the behavior during these conditions, and not everyone will take these restrictions as seriously, because these issues are not communicated sufficiently with everyone. So I'll stop here and can elaborate if there's anything in the questions.
Thank you both. I mean, certainly the things that you've said there reflect findings from a study that we did on sexual gender-based violence and forced migrants, where we found that forced migrants were having to choose between data, hygiene and food, and it was 1 out of 3, and certainly not all 3. So I'm sure that one thing we can do is push for an increase in the asylum allowance, which recently went up by 3p a week, incidentally, for those who didn't know. That's after an extensive review. I'm not sure what an extra 3p will buy at the moment. Okay, I'm going to move on to some of the questions that we have in the Q&A, and do keep adding to those. I'm going to start with Fatma Ibrahim, who asked a question a while ago about something that Yajur said. So you mentioned, Yajur, that financial support is provided to refugees. I think you might have been talking about asylum seekers, with the expectation that they integrate in return. Fatma would like to know a bit more about what these expectations are with regard to integration, and whether there's a specific policy or program that you're referring to.
Yeah, so I think when I was speaking about the integration, I was speaking more on a social sense, rather than a specific pathway, specific policy aligned to integration. So I think we have many different connotations of what it means for a migrant to integrate into the community, or someone from a minority background to integrate into a different culture. So when I was talking about integration, it is more so to do with what people perceive in terms of what the general population perceives as accepting someone that's come to this country. And it's always this notion that if you come to this country, or you come as a migrant, that you need to contribute to the society more so than someone that's been born and raised here. When adding to this general notion of integration, I think one of the main things, at the point that I was trying to talk about, I think, was about how people have issues with employability. And that's because, and that I think essentially, if you're looking at integration, not from the point of view, not from a bigoted point of view, but from the actual point of view where you, how it can impact people's physical and mental well-being, being comfortable in an environment. Employability goes a long way in that, and allowing them to be at comfort and ease in an environment they're in, because that brings a familiarity of work they've been doing their whole lives, environment that they're used to. But more so, it brings a sense of comfort with the financial aspect of it. So a lot of times we'll find that people come as doctors from different parts of the world, and they come here and their English might not be the best, which means that they are no longer allowed to practice as practitioners. These could be people that have been practicing for a decade or two back home, and have been forced to leave their country for various reasons, for fleeing from persecution, for all kinds of a plethora of reasons that could have such horrible impacts on an individual. But they come here and they're not allowed to do something that they've done their whole life, that's given them financial stability, that's given them all sorts of stability back home. And not only does that take away that power from them, and it also has an impact on what they are used to in terms of their status, if so, in society, or their position, or how they are used to being treated, or how they're used to being with a population. But essentially, they come here, they can't, it's not even about people being doctors. There's a lot of people who've been musicians, all kinds of people who've been just put in these positions where they can't do the work they've done their whole lives. They've been professionals that have delivered this kind of service, and they're not allowed to do it. Sometimes it could be because of issues to do with the employer. Sometimes it could be with issues to do with barriers such as language. But I think it's important in terms of supporting people. So there's English classes done by Docs Not Cops Birmingham. I think a lot of other organizations are doing that to help ease this integration. So offering English classes so that people can then be at a certain level that the government or the job requires for them to continue to practice in this country. And there's just some really heartbreaking stories about individuals that were, there's this one person that recorded a video about his experience, and he was forced to be homeless and living outside the train station in Houston. And he was a musician back home, a very popular musician in fact, and he didn't have access to his instruments. He had to leave it back home. He didn't have money to purchase instruments. And no one was accepting the fact that he could actually play music or anything. And he's just talking about how that month where he lived outside Houston, London, people degraded him and called him all kinds of things, called him a burden on the society. And it's just these kind of things that I was discussing in terms of how we can help people get integrated better. And well, there should be a policy or program, to be completely honest, that helps people get into employability after they've come from such volatile situations. And that's a really interesting topic, and that's something I believe in. So I hope that kind of answers the question.
Thank you. Yeah, we're going to move on to a different topic now. So we've got Faiza Hussein who's thanking you for some really interesting and, of course, very concerning stuff. And they've done some research interviewing charity staff about asylum-seeking women who've experienced sexual and gender-based violence. And they've identified a lot of prejudice when these people were trying to register with a GP, including during the pandemic, which of course connects well with what the data is telling us and with what Rita has been talking about. So trying to be, kind of looking forward, they're asking, how is it possible to make sure that GPs are aware of the legislation where people are entitled to primary healthcare regardless of who they are? And I suppose adding to that, because I was horrified by Rita's story of the kind of racism in practices, but also, that actually their behaviour is in fact illegal in some cases. So how can we do that? How can we remove this barrier and make GPs aware of their, or at least GP surgeries aware of their obligations under the law? Maybe Rita, you could respond to that one.
Yes, so we, in 2 years ago, a bit more, we started an initiative called the Safe Surgeries Initiative, and it's basically a network of GP surgeries who commit to inclusive healthcare, to being inclusive. And we, throughout this initiative, we provide trainings to both clinical and non-clinical staff in the primary care, and these trainings, or let's say sessions or workshops, are meant to discuss the challenges they face, and we were trying to understand why they're not meeting their basically contractual obligations, but for the benefits of our service users. So basically we deliver all this information in an inaccessible way about entitlement to healthcare, not only to primary care but also to secondary care. We also contributed with other voluntary sector organizations to develop an audit tool, or like an online assessment tool that will help PCNs, primary care networks, which is basically a relatively new organizing body that is between a CCG and GP surgery. It's like it includes a number of GP surgeries in a certain area, to help them to assess how inclusive they are and to help them to come up with an action plan on how they can improve their performance. We also participate in webinars, in workshops with the Royal College of GPs, with NHS England, with Public Health England, with other voluntary sector organizations to raise awareness about this issue. And we produce regular reports about these issues. Obviously, this is a complex a problem that requires action from, not only from us, but like it requires action at all the different levels. We can't, I will relate to what Azure mentioned about the hostile environment. A lot of what we see, I think, is a result of the hostile environment, because this is exactly what it's meant to do. It is meant to internalize hostility, even without any legal obligations. So even if it's against their contractual obligations, we see this behavior of refusing registrations. And that's because in a lot of the cases, people don't really know. They just internalize this behavior, and they just think that I need to see an immigration status, I need to see an ID, I need to see a proof of address. None of these are grounds for refusing anyone's registration at a GP practice. So obviously, this is something that is extremely difficult to assess and to evaluate, but we can see that this is happening not only in the health sector. We see this in the labor market as well. That is, it's moving into other sectors as well, like into other domains.
Thank you, Rita. And I'm actually going to refer you to a comment made by Alaya, who's a GP, or refers to herself as a GP in the chat, who says that the Royal College of GPs and local CCGs all support the Safe Surgeries Initiative, that Rita referred to, and points out that many surgeries are very much doing their best, but that they are all struggling at this time due to the digital barriers that are being experienced. And that connects well with Helen Nethaway's question, because she's asking about digital barriers, and she's wondering how much this is having an impact during, an access to healthcare during the pandemic. So I don't know who wants to give that one a go, Yajur or Rita, or both.
I mean, one thing that we know for sure, there are hundreds of thousands of people who do not use a smartphone and who don't really use the health applications that are required now to register or to request medications. So that will give you an idea about the extent to which the consequences can be really huge. And obviously destitution is a main factor. So the poorer a person is, the less likely they are to spend their money on data or on, using their phone to contact, to request, to call a GP or to seek medical care. And that's obviously because, one reason is because it wasn't the case, and it was suddenly the case now during a pandemic, and people didn't have enough time to cope or to learn how to deal with the situation, and they don't have the financial capacity. So this could be a reason. I think it is to be seen in the future, like the actual consequences of digital exclusion, because I think it is still ongoing. For now, we know that a lot of people just didn't access healthcare because of it, and it's in hundreds of thousands.
Yeah, I think just adding to that, because obviously with this kind of information, Rita, you probably are dealing with it more on a day-to-day basis and have real-time experience. So it's great to know about that more. So my experience would not be Rita's, is more so from research and elements of the kind of work we've done with different organizations. So that Aston University study I was talking about previously, they had a brief component of it looking at telemedicine when it came to providing antenatal care, and also when it came to providing contraceptions. So that was a big barrier in the sense that for any kind of contraceptive care, you will need a healthcare professional consultation prior to getting any kind of approval. And it's already a bit of an arduous process in which people tend to have a lot of barriers to getting to that point. So there was a telemedicine support that was supposed to have started in England, Scotland, Northern Ireland, but it started in Northern Ireland with some difficulties. It didn't start up in England at the time. This was, again, around April or May, so maybe these services have now started to take place, but that was just one example of a barrier. The problem with that is that women from BAME backgrounds already face a lot more difficulty and a lot more challenges when it comes to care for pregnancy. And it's probably a well-known statistic, but Black women are 5 times more likely to die in childbirth than white women are in this country. So when you look at the background of that, when you look at the background of the fact that a lot of these individuals already face challenges such as requiring interpreters, requiring those kind of support services, and also requiring physical support of a partner or someone to come in with them to these consultations. A lot of those things were also eliminated, which then made it some of the research showed at that point that people were more likely to not access even the telemedicine support service. I think the other barrier that gets presented with digital access to these things is, if you're looking at it from an inclusivity standpoint, it's also about people that come from, that have any kind of learning disabilities or any kind of disabilities that will impair their speech, vision, or hearing. So there's so many challenges when it comes to digital barriers that need to be addressed on the fly. And these services are already not accessed at the optimal level that you'd want it to be in person. So you can imagine how that would translate now to the digital services. So I think that, like Rita said, it will be interesting to see the kind of lasting effects this has, because in the process of it, I don't think they have adapted to it as well on the fly as you'd hope. I mean, there's so many people that don't have access to a phone, and it's just funny because my housemate had a red eye, and then the GP just texted him being like, can you send me a picture on WhatsApp of your eye? and that was the consultation. So you can just imagine how much of a barrier this is causing for so many things.
Can I add maybe just one thing? It's also very important to think about digital exclusion beyond as excluded from accessing the service. Also, even when we are able to access the services digitally or remotely, I think there is the difficulty in delivering quality services, and we see a lot of our GP volunteers and nurses expressing this and how difficult they find it to basically communicate their empathy, to communicate their, like as they usually do in person. Obviously, it is not the same, but it is a barrier to delivering quality service as well for the patients. And it's also very, I think, we know for sure that empathy, the empathetic traditional doctor or like clinician patient relationship is a factor in improving health outcomes. And it will be very interesting to see. We don't know how the lack of this empathy, because we're using remote consultations or like online services, we don't know how this will affect, or will it reduce health outcomes because of that or not. It's just all to be seen. I think we need more time, and we need more research in these areas.
Thank you both. Right, we have a last question in the Q&A box from Olivia Peaty, which also fits incredibly well with what you've been talking about so far. And I'm going to sneak in a question that kind of fits with that as well. So firstly, my question, it's notable looking at the data, just how the numbers of people consulting doctors of the world using your services has plummeted during the pandemic. And I'm wondering if you could give us a sense of who's not using your services and why. And then I think that fits into Olivia's question, and she thanks you for interesting and insightful presentations, but she's asking about the long-term consequences, the long-term implications of what you've presented today, or what we've presented today, and both on the individuals and the groups affected, but also on charities like Docs Not Cops and Doctors of the World. So let's think about those people who are not using services, including your services at the moment, but also those who are clearly being excluded from mainstream health services as well. So I'll hand over to both of you.
Shall I start? I think this is a very, very interesting question. So I think I will focus on who is increasingly accessing our service, because we have to think about our services. We have limited capacity because we can dedicate certain time for each service user, and during the day and the limited hours, there is only a maximum number of service users that we can provide support to in both in terms of consultations and the helpline. So thinking that we have a maximum number of consultations or like of service users that we can actually support, we see an increase in for example, people of younger ages calling Doctors of the World and asking for consultations. We see an increase in asylum seekers. I can't say if this is an increase in their numbers. I mean, we definitely have increased calls and consultations with them, but we don't know if this is a result of a decrease in the demand from other categories. This is very difficult because of the limited numbers of consultations we can take per day. So we definitely see increased numbers of calls from people of younger ages, asylum seekers, and with the younger ages, it could be, obviously this is something that we need to spend more time, and we need more time to understand what exactly happened. With the younger ages, I think the reason might be that we have a health concern that each single one of us has a health concern during this pandemic. We might be very, very healthy, and now, but we know that there's a pandemic happening, so we need information. We become paranoid. Oh, I'm coughing. Oh, do I have a fever? It's just extremely difficult not to be drawn into this. So young people might be healthy, still calling because they are afraid, because they are concerned about something that is new and we don't know enough about it. About the asylum seekers, it is again a continuity of all the points that we raised previously. They are in legal limbo. They live in very insecure, and they have a very insecure income. Most of them are destitute. They can't work. Even if they are able to find a job, they can't work, and they are not allowed to. And we also have shared accommodation, very dangerous in a pandemic. So for all these reasons, and inconsistent and insufficient health services in their accommodation. So for all these reasons, they are looking for alternatives. They're looking for alternative, not only health providers, but sources of information as well. So it's again, a lot of these questions, we will have better answers in the future. We need more information. For now, this is my analysis of what we saw so far. One thing as well, obviously it took us some time to move into the remote consultation system. So there was a point when we ourselves were trying to cope with this model. So obviously we were able to take less number of consultations. Now we are much better, we progressed, and the system is well in place. But obviously there was a transition period where, you know, the system was not working at it, you know, like it was just, we were all coping and trying to learn how to deal with that.
Yeah, I think it's very, the question itself has a lot of elements to it. So I think in terms of the longer term implications of what we present, will be of what you presented today. So I think if we're looking at specifically the impact that vulnerable population, the access to care for vulnerable populations and how that's been analyzed by this data, and furthermore in the context of COVID-19, I think that this is the start of a lot more research, and this has created a lot of guidance and recommendations that we can then find further insights into in terms of how we can actually continue to tailor support to vulnerable populations and what we can do to make that support equitable and accessible. I think looking at the current standpoint that we're at in terms of healthcare during the pandemic and how this impacted health services and other organizations, I think in terms of charities, it's really disappointing, but we could be in a situation where a lot of charities will not be in a position to restart or to resume their services. And that's really disappointing because a lot of provisions for care that is given to populations at risk or populations that are vulnerable are through these charities because of the work they do that's specifically targeted at these populations, whether that's mental well-being, whether that's any kind of other form of support socially or in terms of financial support. So I think that is something that I was keen to see how it changes and how support is provided to help rebuild these charities, because they really are the backbone of the support that's given to a lot of specific populations. And it's really disappointing to see how they've been not really given the support that I believe they should have. I think on the whole, if we're like looking at what this means for healthcare, it just goes to show that you can't detach politics from healthcare, unfortunately. And a lot of what we're seeing today and a lot of the impacts that we have are directly to do with people in those positions and not to do with the people delivering the healthcare who are trying their very best and who are, for the most part, on board with delivering healthcare for all their patients. So it's those policies really that trickle down and then have these harmful effects on all these populations. And it's about challenging them from a public health and health policy standpoint. There has been so much corruption that we've seen, so much, the interpretation of so much data has been done so poorly, or the collection of so much data, and the modeling of so many things that we've seen now has been done poorly, not because we don't have people that are competent, but because more from an administrative standpoint of who has been allocated those roles. There have been so many things that have been exposed. There's not enough doctors in public health. There's not enough people in infectious diseases. There's not enough people with healthcare backgrounds delivering health policy and also looking at health economics. So I think it's interesting to see this all sounds really negative. So it's interesting to see where things are going wrong, but in a positive light, it's also important to note that everyone that's been delivering the healthcare has been stellar in what they're doing. And we need to find ways to support those people on the front line, and back them up with better policies, with better administrations and better administrative services that will promote more health education amongst patients and healthcare professionals. And yeah, I think just in terms of patients itself, I think investment in health education can go such a long way. And it's just some of the promotional campaigns that were done at the start of this pandemic. I mean, how did it take 3 months to start promoting the fact that people should wear masks? It just goes to show that health education has to be delivered from younger ages. I think it's something that should be integrated into curriculums to a degree, and just promoting that kind of awareness. So there are a lot of things that we can take away from the pandemic that could directly change how we perceive healthcare and how healthcare is taught and delivered, and how policies for healthcare are made. And I think that as bad as things have been, it kind of has created a focus that you can't turn away from now, that I hope a lot of people are inspired by, to then take up these fields and then to be like, we can't let this happen again. And even the fact that it's happening now, trying to change it now, is also really important, because this is something that's going to be with us through 2021. So yeah.
Okay, thank you very much, both of you. And we're in our last couple of minutes. So I'm going to hand over to Laurence to maybe just reflect very briefly on the implications of the discussion for the project, and perhaps give us a few pointers as to where the project's going to be going next, and what everybody can look out for. Over to you.
Yeah, absolutely. Thank you very much. Thank you very much, Rita and Yajor, for the very insightful reflections. And that, I think, gave us, actually has given me a lot of food for thought in terms of where we can take the data further for the project, including exploring some of those notes, exploring the notes and getting a bit more contextualization to the questionnaire data that we have, using some of the consultation notes. And also, Rita, what you were saying about the kind of the profile of people consulting, especially over time, and the potential change as the pandemic has gone and as the different lockdowns have been implemented. I think that's definitely something that we're going to be looking into absolutely in the next few weeks, I think. And I think the discussion, especially the last discussion, has also, not from a project perspective, but from a perspective of social scientist, I think the pandemic and also the discussion that we've had today has re-emphasized my, I guess, personal / professional conviction that there's definitely space for social science and social science knowledge to take part and to be included within the discussion on the pandemic, on the effect of the pandemic, within this broader topic, but also within the topic of the pandemic in general. So I'll keep it brief because we have 1 minute left.
Thanks very much, Laurence. So what we've done is we've put a final slide up. So you've got the link to the project, obviously, to Doctors of the World, Docs Not Cops, and you can see some examples of Penn's work as well. We're also asking you to complete our evaluation questionnaire. This is the first time that Festival of Social Science has been a virtual Festival of Social Science, so we want to hear how it was for you. I mean, certainly one thing we've learned over the last few months is that, there are the odd silver lining here and there, and the fact that we've had people coming along from places like Brazil and joining in today, that never would have happened if we weren't virtual. So, it does bring some positives. To finish, I just want to say thank you all so much for sparing your lunchtime today. Thanks to all the speakers, specifically to Yajur and to Rita, who've taken time out to participate and fill us in on some of the the real detail behind the findings, to the project team, Lin, and to Laurence. and to Liz for helping us with the tech. So thank you very much. I hope you all have a good weekend, and keep up the good work, everybody. Bye-bye.